My name is Akutu Munyika. I'm a specialist general surgeon with interest in minimal access surgery, also very keen interest on clinical research. And without further ado, I would like to proceed with the presentation. The only disclaimer I have is I've borrowed some of these slides from Professor Janice, who's at the University of Boston, the School of Public Health, who are really the public health are really the custodian and the experts when it comes to detailed aspects of clinical research and study designs. So there are a few concepts that we have to go through when we talk about study design, whether it's in surgery and other fields, aspects of bias and variability, randomization. Why is randomization important? How do we randomize? What about blinding? Patients blinding, the researchers blinding, clinicians blinding. Why is it important and how? And then we'll look at a few general study designs that could help us when we design our study in surgical clinical research. Just to look at these two concepts of bias and variability, the clinical trial is considered to be a gold standard when it comes to clinical research. The results and the outcome of clinical trial are considered to be gold standard. The clinical trial provides the ability to reduce the effects that are produced by bias as well as variability that can obscure the true effect of the treatment or the procedure that is being looked at in that trial. If you look at it in simple terms, bias affects the accuracy of a study. So the effect of bias in a study, it affects the accuracy of study, and you want to minimize as much as possible the bias. The variability affects the precision of a study or of a trial. So any influence which act to make the observed result non-representative of the true effect of that therapy or of that procedure, it's then considered to be bias. Let's look at some examples. For example, a healthier patient given treatment A and a sicker patient given treatment B. So just by knowing that treatment A is given to a healthier patient and treatment B is given to those who are very sick, that is an important bias to be considered and to be minimized. Treatment A, if it's new and exciting, so both the physician and the patient expect that they will have better results or good results. So in this kind of example, there's many potential sources of bias. On the other hand, if you look at variability, the high variability makes it more difficult to discern treatment differences. Okay, what are some of the sources of variability? One can look at, for example, the biologic makeup of the individuals, or the instruments, the measurements which are used, like instrument as well as the observers. So, and cannot always control all sources. It's not always possible to control all sources of variability. And we'll share some examples. So the fundamental principle in comparing treatment groups. So groups must be alike in all important aspects. And the only difference should be in the treatment aspects of these two groups. So for us to minimize this issue of bias and variability, we have to make sure that the two groups which are being compared, whether it's a treatment option or whether it's a procedure that's being compared to a used or a known procedure, the two groups must be as alike as possible so that we can minimize the effect of bias and variability. So in practical terms, comparable treatment groups means alike on the average. In other words, you have really matched group A and group B in terms of their differences. And the only difference that's going to be there is on the measured treatment or procedure. Why is this important? If there is a group imbalance from an important factor, then an observed treatment difference may be due to that imbalance and not necessarily from the treatment or the procedure that is being tested. An example will be drug X versus a placebo for osteoporosis. Age is a risk factor for osteoporosis. So older subjects who are enrolled with drug X, and then what you then look at is that how does this age become a confounding factor? How does it affect the outcome if age is already a risk factor for osteoporosis? So the treatment group comparisons will be biased due to this imbalance of age. How can we ensure comparability in these treatment groups? We cannot ensure comparability 100%. It's almost impossible. But if we then introduce this concept of randomization, this will help us to balance all factors between the treatment group. And this is where the concept of randomized controlled trials comes in. And this is to try and reduce all these factors which will reduce the accuracy of the outcome as much as possible. So if randomization works, then groups will be similar in all aspects except the treatment group. So recall that we said that it's probably not possible to effect 100% comparability because some of the factors we may not have control over. So the introduction of randomization will then help us to match the groups as closely as possible and only expect the effect of the treatment or the procedure that's being tested to produce the results that we want. So we are then going to look at this concept of randomization. Allocation of treatment to patients is carried out using a chance mechanism so that neither the patient nor the physician know in advance which therapy will be assigned to which patient, basically. So the simplest case to look at it as an example, each patient has the same chance of receiving any of the treatment which is being looked at, or each patient has the same chance of getting any of the procedures between the two procedures which are being tested. This is where randomization comes in. There is simple randomization that can help us to further understand this. So we think of a tossing of a coin. Each time a subject is eligible for randomization, you toss a coin. If you end up with heads, that patient goes to treatment A. If you end up with tails, that patient goes to treatment B. This is a simple randomization. So approximately, and we have to say approximately, half of the group will be assigned to treatment A and treatment B, because you may also still not get the exact number. If you are having a group of patients being 20, you may not necessarily get 10 and 10 on each side by flipping a coin. So randomization usually done using a randomization schedule or a computerized generator. And this will ensure that the numbers are more or less equal. This is now compared to tossing a coin. The problem with simple randomization is that it may result in substantial imbalance. An important baseline factor, for example, can be affected. The number of subjects assigned to each group, like we've mentioned, you may not get exactly 10 and 10 on each side if you are using a simple randomization technique. So the solution to that is to use blocking and or stratification or stratified randomization. And that is how, for example, computerized randomization calculations are used. If you look at what blocking a randomization or stratification is, if we can look at blocking example, if we have two treatment groups, group A and group B, we can then have this equal allocation, and by doing a block size. For example, here we are talking about these combinations, right? And this can be chosen, and a computer can easily generate this. It can also be done manually, but we have now better systems to do this without taking up too much time. So these are the possible combinations between group A and group B, is stipulated here. And blocking ensures the balance after every fourth assignment or after every fourth cycle. So there will be a clear balance. So there won't be one group which is having more compared to the other group. Stratification, on the other hand, ensures a balance on an important baseline factor. So you create a strata and set up a separate randomization schedule within each stratum. An example, if we want to prevent an imbalance on age, in that example that we have given of osteoporosis, first you create a strata. For example, the age below 75 and the age above 75. Then you randomize within each stratum. By doing that, you will then get a better way of randomization and reduce the bias of the risk factors of age. Blocking should be also be used with each stratum in this case. So what are the other alternatives to randomization? Randomization is not always possible. And this could be due to issues like ethics, practical considerations, and there are some other alternatives that that can be used. Historical controls, non-randomized concurrent controls, different treatment per physicians, systematic alterations of treatment. So the sources of bias for these alternatives need to be considered, and perhaps we'll just briefly look at some of these things. The other concept that we mentioned that is very important is that of blinding when it comes to clinical trials, and especially on testing out new treatment or new procedure against a known treatment or a known procedure. Masking the identity of the assigned intervention. The main goal is to avoid potential bias, which is caused by conscious or subconscious factors. And this is blinding. So there's different types of blinding. There's single blinding, where only patients are blinded to what they are being subjected at. For example, they don't know if they are getting treatment A or treatment B. So this is called simple blinding. Double blinding, the patient and the assigning investigator are both blinded. They don't know, the investigator doesn't know, the patient doesn't know. That is called double blinding. Triple blinding, committee monitoring the response or the variables, such as the statisticians, they are also blinded, in addition to the patient and the investigator. How is blinding done? To blind patients, one can use the placebo. For an example, the pill that is given for this treatment study can be of the same size, same color, same shape. So the patient can't tell, right? If you are looking at blinding the patient. If it's the same operation, okay, the anesthesia that's given, the incision that is given, it's the same. The procedure is done differently inside the patient's abdomen, for an example, but the type of anesthesia, the type of the incisions is the same. So when the patient wakes up, it's exactly the same. And this can be given to other examples as well as stipulated. Why should patients be blinded? The patient who knows they are receiving a new or an experimental intervention may report more side effects, for an example, or less side effects, because they know. and they might have other factors that may influence their decision to answer the relevant questions that are asked. Patients not on a new or experimental treatment, on the other side, may be more likely to drop out of the study, all right, or less likely to drop out of the study if they know that new treatment has been spoken about in media, people have reported good benefits, and they are told that you are going to get the old treatment. Obviously, they might think, why should I be subjected to the old treatment? So they may have those effects. Patients may have preconceived notion about the benefits of the therapy. They might have heard about the side effect of the new treatment, or they might have heard how the old treatment doesn't work. So this is where the importance of blinding the patient comes into play. Patients try to get well or to please their well-known clinician or physician, or maybe they have been with this physician for a long time, so they want to show good effect, they want to show good results. So these are all aspects that can inform why patients need to be blinded. So if we look at the placebo effect, the response to medical intervention, which results from the intervention itself, not from a specific mechanism of action of the intervention. So the placebo effect. So just by knowing that I'm actually not getting the actual treatment, I'm getting the placebo, there could be some response that will come, and not necessarily because of the action of the treatment, but just because I know that I was given the placebo. So blinding patients, not knowing whether they got the actual treatment or the placebo, becomes very important. And there are very, very various examples that are given in literature. This is one of them, which was published some time ago, where you have 46 patients with chronic severe itching, randomly given one of the 4 treatments, and they can then have an itching score, and the treatment is given there, and they can be scored. So those who were not given anything, those who were given a placebo, the way they respond to these questions of the itching score could be the reason why their results could be because they were not blinded, so they don't know, or rather they know what they were given. So the score is going to be very much confounded and may not give a true reflection. And many other examples can be given. Why should investigators be blinded? The treating physicians and outcome assessing investigators are often the same people, especially when it comes to our clinical trials. So the possibility of unconscious bias in assessing the outcome is difficult to rule out. So this is why the investigators are blinded, or this is why it's important for them to be blinded. Decisions about concomitant, compensatory treatment are often made by someone who knows the treatment assignment. So if we know, for example, that open appendectomy is good, and the effects of laparoscopic appendicectomy or the outcome is not very much different. So if we are the ones who have been doing open appendectomy and we want to study now the effect of laparoscopic appendectomy, and there is no blinding involved, it's more likely that because you have been comfortable with open appendectomy, you might be confounded with bias subconsciously or unconsciously. So, but if the investigators of the outcome of the study are blinded, you will then reduce this issue of bias. Can blinding always be done? And the answer is no. It's not always possible to achieve this 100%. In some studies, it may be impossible or even unethical to blind, to create blinding. A treatment may have characteristic side effects, right? It may be difficult to blind the physicians in a surgical or a device study. And the sources of bias in an unblinded study must be considered and must be disclosed. That because of this, we could not create this blinding, or because of this, we have to consider this certain bias. as long as that is disclosed and mentioned, that could at least inform the reader of what is happening. Right. There are a few other general study designs that one could possibly mention. Many clinical trial studies designs fall in the category of either parallel group, dose-ranging, crossover, or factorial designs. And these are concepts that one can possibly familiarize themselves with. There are many other possible designs and variations on study designs. And here we'll just look at a few considerations. General study designs, when we talk about parallel group designs, this is one of the simplest way that the groups can be assigned in parallel manner, where you've got what is being looked at, or the intervention or the study, and the groups are aligned in the parallel design setup. You can have the control, and you have group A, B, and C, and then you monitor them in the parallel session like that. The dose ranging studies, depending on if you are looking at the dose that is being studied, you can have the control, high dose, medium dose, low dose, and look at the effect and the outcome, compare them to the control group. Then there is a crossover design where, depending on the intervention that is done, you can have a stratification where you have group A, group B, introduce the measure, whether it's now a procedure or a new treatment, and study the different groups by crossing them over. This is also a different types of study design that has been looked at. And like I said, there are many others, but this is just to mention a few. And then there's the factorial design, where you can mix the groups up, where you've got group A and group B. You can mix group A and control. You can mix group B and control, or control and control, and look at whether there is any differences in outcome, and stratify them and come up with the results of what is being looked at. I'm quite hesitant to go through the details of the crossover designs and the different designs, their advantages and disadvantages, because these do not necessarily inform to what the topic is, which is really to look at the issue of randomized controlled trials in surgical trials. So I would end the presentation there and leave some time for any interactions. Thank you very much.
Thank you so much, Dr. Akutu. We still have some time. Maybe we can accept a few questions from participants. If anyone have a question, can raise a hand or can also type in the chat box.
There was someone who could not hear us. I'm not sure if they eventually got to hear the talk. Kuom, perhaps they can get the access to the recording, and they can perhaps go through the brief talk.
All right, so we have recorded everything. So we'll be sharing this. I've shared the initial QR code where everyone will be able to access the current talk as well as the previous ones.
Great. Once again, thank you very much for the opportunity, and we look forward to further discussions. There is one hand up. Vigni? I think you are muted. Maybe it's an old hand.
You can unmute yourself and speak.
Okay, might not be a hand. All right, so we'll then maybe give a chance to Peter to talk about the importance of. How are you in? Okay.
Yes, please. I just wanted to find out where precisely can one have the QR code to have access to the previous sessions.
That will be shared at the end of the the talk. I shared it initially, but we'll be sharing this every time when we start our sessions. So don't worry about that.
All right, thank you.
Thank you very much, Godfrey. I think we can move on to surgical audit by Peter.
Thank you so much, Dr. Akutu, and looking forward to meeting you and speaking further. But now, without any further ado, I would like to welcome Dr. Peter Nthumba. Dr. Peter Nthumba, please welcome, introduce yourself, and take us on the surgical audit talk. Thank you so much.
Thank you, Philip. Real quick, can you see one screen, or do I have a split screen so that then I am able to proceed?
No. We can see one screen, so I think we are good to go. Yeah.
Thank you. Real quick, I am a plastic surgeon and clinical epidemiologist, working at AIC Kijabe Hospital and associate at the Department of Vanderbilt University. And we're going to be talking about surgical audit. Thank you very much for the talk on the clinical randomized clinical trials, which I think is something we need to be doing within our facilities. So I'm going to run through definition of a surgical audit cycle, look at scope and standards, discuss data collection, interpret results, look at what effective audits look like, and then consider different types of audits and audit tools, and finally close with a relationship between or the move from audits to research. Why do we perform audits, and what is a surgical audit? I think it is important to start off with a statement that the primary purpose of an audit of surgical practice is not to promote scientific inquiry. It is primarily a QI, quality improvement process, but it nevertheless lends itself to research, and we'll see how we can turn surgical audits into research. I need to be able to move my slides. Okay. I don't know why okay. All right. So what is a surgical audit cycle? Sorry, I was previous. What is a surgical audit cycle? What is standardized tools exist? And the preamble is surgical audits are important QI tools that work best in an environment of a just culture. And a just culture is a place where everyone feels safe and able to contribute robustly to any discussion. Blame culture, which unfortunately is rather prevalent within our surgical community, it kills novelty and will stifle surgical audits and other attempts at developing patient safety culture. one of the things that kills a just culture is, this is what I've always done. When a student, for example, asks, why are we doing this? Oh, I read about this. So a safety culture says, or a just culture says, that's an interesting idea. I'd like to listen a little more, and then I'll go home and think about it. Surgical audit is really a systematic quality improvement process that utilizes critical analysis of the quality of surgical care to improve patient care processes and outcomes. It looks at diagnosis, it reviews treatment, and considers resource utilization. For example, in a post-op patient, when is it appropriate to use a complete blood count versus an HB only? When do you order which? What factors do you consider to order this? That is a resource utilization process. Surgical audit is reviewed by peers against set criteria or recognized standards. So as an expert, my job is not to use a surgical audit and use myself as the standard and against which to measure, but rather use recognized standards. Institutions may develop their own standards against which we can review, say, our departmental audits. Surgical audit is used to further inform and improve surgical practice with the ultimate goal of improving the quality of care for patients. Because our patients are entitled to high quality surgical care, I'd like to remind all of us here that indeed our patients are our primary employers, and therefore they deserve the best. So surgical audit is comprised of measurement, comparisons, and evaluation that include a peer review process. So in measurement, what are we measuring? The comparison is against a non-standard criteria, and a peer review allows for a process of peers to reflect on the results of the audit, propose interventions where necessary, or applaud the measures that have been taken. It also allows for the team that is present, the peers, to look at previous activities, QI processes that have been undertaken in previous audits to review progress. So to be systematic, audits should be regular. They should be recorded with clear notes on action points and timelines, and multidisciplinary. Outsiders outside the department are more likely to look at us with and see where our faults or our strengths lie. To be systematic, they should be inclusive of all team members. That means every member of your team, including the scrubs, the nurses, the anesthesia, the ward nurses as well, ward staff. They should all be members of the entire patient journey through the hospital. Should allow its review should be by every member of the team. It also should be inclusive of all the patients admitted to a given service or seen by a given service, so that all morbidities and mortalities within the service are discussed, and interventions to avoid similar complications in future drafted and reviewed. The surgical audit cycle is based on a five-step cycle, which is scope, standards, data collection, interpretation of results, intervention, implementation, and monitoring. Remember, interpretation of results is an important part of the peer review process. We need to determine the scope of our audit. Spend time considering areas of surgical practice for review, because it is impossible to do an audit of everything that we do in terms of activities within a hospital. We may choose, for example, so every time, for example, we present every quarter, our department presents quarterly to the entire hospital. And what we do each time, we'll present all our patients for the quarter, but we focus on our biggest weaknesses. For example, it might be surgical site infection. And as a hospital, the hospital might determine to do a surveillance. The beauty about that is that there is a validated tool by the WHO that allows for a 30-day follow-up using CDC definitions. Of course, SSIs will affect the length of hospital stay. And so it's possible to look at the cost of SSI management, the cost of MDR treatment within a hospital, allowing for antimicrobial stewardship processes to step in and help. Other things that you could look at is return to operating room rates, or look at procedure-specific complications, or turnover time, patient-reported outcome measures, which are not very well done in our part of the world, where patients report what they think their experience were like, remembering that our patients are primary employers, but also our most important clients, so to speak. What they think about the care that we provide is important because it allows feedback and for us to be able to then provide them a better service the next time. And then a QI process could be the use of investigations. It's important for the team to determine what standards that we'll use. There are all kinds of criteria, documents that are available in literature. I think it is important to contextualize our choices because the tools may not be appropriate for our practice or our type of practice. So looking at what we do and looking at what is in literature and figuring out where we meet. They must, however, be evidence-based or at least existing local guidelines. We could do a systematic review of an available body of evidence to develop new guidelines. There may be specialty-specific guidelines. For example, I know the cardiothoracics have their own surgical site infection prevention guidelines, as do the colorectal surgeons, et cetera, So using a specialty-specific guidelines and then contextualizing it to your own hospital. Or it could be a body of experts. Remembering the first hand hygiene guidelines was developed by a body of experts because we did not have any literature at the time. I think it is important to note that in the process of introducing a QI process, it is important to go through ethical approval. Most QI processes receive a waiver. The issue is that frequently our QI processes are just a thought, a process, and then at the end you have such good data and such good outcomes, you want to report what you did for the purposes of the improvement of other institutions, etc. But then you skipped one thing, which is ethical approval, and then it becomes impossible to proceed. Consider the variables that you need to answer audit questions, and then think about what your data source is like. If you're going to use hospital records, it's important to make sure that the data points or the variables that you need are within the hospital records. Otherwise, one needs a fresh data collection tool that will collect all the variables that you need to evaluate whatever QI process you're looking at. And consider what type of data you'll be looking at, prospective or retrospective. Think about who collects data. when is it collected? How will it be collected? Is it during or after the operation? Is it electronic or paper-based? Then what frequency? Is it all the patients? Is it every other patient? Like I said, if it's not already in hospital data collection tools, so clinical records, then we need an additional tool like this WHO tool for surgical site infection surveillance. And follow-up data, again, the WHO has this tool. So are you going to use phone calls? Who's going to call? Will the patient know? How well will they be prepared to answer the questions? How long are the questions you're going to be asking? Those are important thoughts about your audit. What is your patient participant selection like? You need to determine a case definition, that is boundaries. If it is an SSI surveillance, for example, it is within the 30 days post-operatively. Are you going to do a randomized process? Is it purposive, etc.? And we talked about data sources. There's some noise in the background. I don't know whether that's a question. We come to interpretation of data results. Like we said before, it is important to have a known standard. The discussion with the peers is at the point of audit presentation to the multidisciplinary team that we discussed before. And hopefully this is a process that's been set up by the institution. Then as a team, as an MDT, agree on interventions that hopefully will lead to an improvement. Is it new skills that are needed for the team or for members of the team? Is it changes in practice or in systems? What time should antibiotics be given? Is it so if there is a 10 o'clock on your the last shift for the day, they left rather late, would be leaving at around 7 when it was dark. The nurses were attacked. And so the Nursing Council in this country helped a process of changing the shift so that the last shift ended during the day while there was still light, and therefore they could travel safely, and the ones coming to work could travel to work safely. And so a change in systems. Interpretation, we've talked about a clinical meeting. Peer review is a learning process. Avoid blaming others or bragging because it discourages innovation and reporting. Essentially, we'll create an environment for developing an unjust culture where you feel sharing data or information is not safe. As mentioned, change of practice as guided by results. Objective confirmation of improvement is important. Again, using tools, implementation, ensure all stakeholders are carried along the entire process. That means the multidisciplinary team should look at the process of implementation, and then in a standardized process, monitor the impact of that implemented program. And if it is across one surgical discipline, there is success, then that can be carried across the entire institution. The interventions may be at different levels. It's very unusual that individuals are the primary source of problems in patient care or patient errors. It's less than 5% that specific individuals are at fault every time. Most frequently, it's a systems level problem, and blaming individuals does not help, but makes it difficult to report problems. When I know that it is safe for me to report a mistake, an error, and again, I'm reminded of we shifted from morphine from pethidine, and the dose difference is tenfold. So, 0.1 milligram per kilogram body weight versus, I think, 1 milligram per kilogram. So a nurse gave morphine using the pethidine calculation. Immediately, she came up to me and said, I've given this, so this patient is at fault, is at risk. We got everybody around the patient, sorted out the complication, watched over the patient, and the patient was safe because the nurse recognized they'd made a mistake. They knew they were in a safe environment, were able to report, and the patient was saved. So it's important for people to feel safe. Philip, is it possible to mute whoever it is that's chatting,
Yes,
please?
I have done so, Doc.
Thank you. Thank you. So if it's a systems level, is it the team? Is it at the institutional level? Is it a national problem like the nursing problem with the shifts? And so then that problem is addressed at that level. Effective audits promote a culture of audit. They help grow patient safety. They help develop a just culture. They should be productive peer review. And then there are educational processes, because the more senior members of the team can show an open, transparent process of learning and recognizing errors and mistakes. And so the students are able to learn so that they don't repeat the same mistakes. Then institutional ownership of the process and proposed changes is important, because then the institution allocates time and resources for specific processes and changes. The institution is able to set up resources to oversee and verify the process of data collection, and also oversee systemic improvement opportunities. There are different types of audits. There could be personal audits, or could be hospital audits. A personal audit may be all surgical operations or specific types of operations. These help identify patterns, trends, procedures, and outcomes, including morbidities. So, what is the rate of, I'm a plastic surgeon, so what percentage of my skin grafts fail? What's the average take? And so that becomes an important piece of information, because when we look at that, how many, our donor sites, how many of them, what percentage get infected, what changes do we need to make? And that leads to patient care improvement. Hospital audits may be maybe a selected procedure, CV, central venous line. How long should it stay? How many actually get infected? Or procedures of a selected time frame. So clinical unit audits. The clinical audit could look at individual surgeons, or look at individual units. This is an old paper that was published by the East and Central African Journal of Surgery, where I looked at procedures that I was involved in at the time. Audit tools. The Clavian-Dindo classification of surgical complications is one common classification. A lot of institutions have adopted this to fit their own contexts. I know Kijabe has its own. Unfortunately, I did not put it in a slide, but I could always share it later on. This is another audit tool, looking at whether the procedures are the urgency of the procedure, whether it is a minor procedure or a major complex procedure, and of course the ASA classification and the scores. This is a physiological score that you could use for patients. And so using this scores allow us to use standardized processes to evaluate what we're doing and the outcomes of patients. Now, surgical audits and research, I think I just decided to share a few of papers that I've had the privilege of publishing, but these are they may look like a series of cases, etc., but it really ends up just being that an audit process, because you look at you report outcomes and complications and return to the OR. So this presentation is a teaser for the potential benefits of surgical audit. It is not exhaustive in any way. Each institution needs to consider, adopt, and adapt a tool that best suits their needs and environment. That's my email, and I'm involved in a number of research groups that reach out to try and teach our residents hands-on clinical research. And so you're welcome to reach out to any of those groups or reach me after this, and we'll see how we can walk that journey.